Everyone. My name is Heather Paladine. I'm one of the board members of the FMEC. And thank you so much to all of you for coming to our presentation, one of the highlights of the fall FMEC conference from last year on gun violence and its impact on individual, family, and community. So just a little bit about the FMEC. I suspect most of you are familiar, but we're an organization based in the Northeast US to promote family medicine and strengthen family medicine, as well as our care of patients, particularly focusing on this Northeast region. We have a conference that rotates around the Northeast region of the US every year in the fall. This presentation was one of the highlights of last year's conference in 2022. And you can join us in Providence in October to hear more highlights from the FMEC. And now I'd like to introduce today's speakers from St. Luke's University Health Network. Cam Lamb and Renata Carnero. And I mentioned I've been very much looking forward to this talk. Thank you.
Thank you for your patience. Dr. Carnero and I would like to share the impact of gun violence on individual, family, and community. Thank you, Dr. Paladine, for introducing us, and thank you to the FMEC leader, Mr. Scott Allen and Dennis Steele, for organizing all this. And thank you all of you for joining us in this lunch hour of yours. Hopefully you find something useful from this talk. So here are our contact information. And we have nothing to disclose beside the fact that we are faculty in the Bethlehem Family Medicine residency program with St. Luke University Health Network. As for learning objective, we hope in our hour today, we will share with you some statistics and effect of gun violence in the US and in our own community. We would like to share with you the statement from the American Academy of Family Physicians, American Academy of Pediatrics, as well as American Psychiatric Association and their associated guideline. And along with all these guidelines, hopefully we'll share with you the practical screening guideline and advice for our patient that we can discuss with our patient for shared decision-making at preventive visit, but also some specific strategy for individual practice, the community, and beyond. And then at the end, we hopefully to incorporate trauma-informed care as a preventive strategy for us all to consider.
So as we're talking about gun violence, we want to highlight that September 17 is Physician Suicide Awareness Day. And we want to bring attention that about 400 physicians die by suicide every year. And there are plenty of resources with Dr. Lana Breen Foundation in terms of preventing physician suicide and raising awareness about the importance of mental health and gun violence. So it's important to highlight that suicide, about 50% of the suicides gun are used. And there are other points of there for the violence as well.
So gun violence is definitely a national public health epidemic that affects a significant portion of populations at many levels, including individuals, family, and community. And as family physicians, we're not only at the front line to see the impact of gun violence in our patient and their family and the community, but also we are in a very special position that we can talk to our patient and our community to improve the safety and well-being of these growing concerns. And when we discuss gun violence, we would like to address homicide, violent crime, attempt suicide, and suicide, as well as unintentional death and injury. In this slide, you can see the sobering statistic. In the recent article in May of 2022 in New England Journal of Medicine, it was reported that death by firearm is now #1 cause of death in children and adolescents. And if you look at the graph next to it, the orange line, finally in the year of 2020, actually it exceeds the previously number one cause, which is motor vehicle accidents. So in 2020, we have more than 45,000 children and adolescent death that caused by firearm, which is really sad. So with this, the call of action statement from the American Academy of Family Physicians. So the AFP is joined by the American Academy of Pediatric, along with American College of Physicians, ACOG, and American Psychiatric Association, urging the president and the Congress to do 3 steps to help addressing gun violence. First of all, label violence caused by gun as a national public health epidemic. And as you can see, even just this week or previous week, gun violence is just happening too often around us. And with that call to labeling it as a national public health epidemic is to fund appropriate research as part of the federal budget to address this concern. And then establish constitutional appropriate restrictions, especially on large capacity firearms that feature with rapid and extended killing capacity. So with all of these 3 requests, basically from various physician groups, we emphasize the need to treat gun violence as a public health epidemic. In the call for American Academy of Pediatric, the statement includes the most effective way to prevent firearm-related injury in children is to keep gun out of the home and the community. And specifically, I put in the whole long statement here, but there are 2 main points. First of all, the pediatricians, the family physician, those who take care of children and adolescents need to address the dangers of having gun in the home and exposure to kids and adolescents with guns. So the AAP recommend that when we see children for well-child visit, we need to ask whether there's firearm in the home. And if there is firearm in the home, we need to address safety feature to keep and storage of firearm. However, the home that is safest is the home without a gun. In bullet point number 2, the presence of gun in the home also increased the risk of lethal suicide among adolescents. And in particular, healthcare professionals need to pay a lot of attention to adolescents and children with mood disorder, substance abuse problems such as alcohol, and history of suicide attempt, because this increased the children and adolescent risk of dying and injured by firearm.
So very similarly, the American Psychological Association also talk about the urgent need to address gun violence. And look at gun violence is a very complex problem. It's not something that is just one layer. It's multifaceted. And we need to be focusing on 3 key areas: prediction, prevention, and policy. So with that in mind, one of the things that we look from developmental approach, how gun violence occurs, right? We have to look at some of the risk factors as well as some of the protective factors. So what are some of the risk factors that might influence somebody to be the perpetrator of gun violence one day? It's very difficult to come up with a specific profile that say, like, if we have those 3 key ingredients, this person is going to be more likely to be a perpetrator. But there are a couple of things that we need to pay attention to. How gun violence sometimes can be normalized in some communities. We also have to pay attention on the effect that it has on the individuals and the families, and also in the school system, and some of the social cultural risk factors that you might be able to see over time. And if we have those multi-layers of systemic thinking involved on how we can prevent this, right, then we can focus on helping our patients, their families, their school, and the community in general. So looking from this very systemic layer, right, we look how all of those systems kind of interact with one another. We have some of the individual characteristics that may influence their behavior, right? And including with that, some beliefs and perceptions regarding gun violence, and even knowledge. We will later be talking about some strategies that address that. We also can think about relationship issues, right? Any interaction of relationship, IPV, and things like that you can be thinking about that can contributing to the problem of gun violence. And then we think about different a little bit more broadly, thinking about in terms of community. and community settings and different kind of organizations and groups and the school and workplace, all of those layers interact with one another. And again, we're looking even a bigger layer, which would be society, our cultural norms, and our education and policies and federal laws that we can do to help and prevent gun violence. So we are going to talk a little bit about some of those cases that we actually have here in our clinic. I want to point it out, my role in the clinic to facilitate the conversation about these cases. So I'm a behavioral faculty here, and one of my roles is to teach the residents about behavioral medicine. And the other component is I also see patients here for therapy. So we have integrative behavioral health within the Family Med program. So let's look at this first case of one of my patients. Was a 40-year-old African-American woman, and she was recently discharged from psychotherapy. I had seen her for about 6 months, and she was discharged. She was doing really well. But then she came back again for a visit with her family doc, and she had an increase of anxiety. And her anxiety that was treated before and she was discharged was triggered by mass shootings that had happened recently. And she had reported that she didn't feel safe. She didn't feel safe going outside of her house. And then she also reported being afraid of taking her small children to school. So if you think about this patient and you think about her experience, right? What are some of the ways that we can conceptualize her anxiety in terms of her individual characteristics, right? As a woman of color who is 40 years old and have children at a school age. And then think about how some of her relationships may be influencing her anxiety, and what would be like the role of the community where she lives, and also in terms of society and the cultural norms regarding of specifically her and her ethnic group. So I just want to open up to some of those questions to see if anybody here would like to talk with us about what would you see in this very brief case scenario that you think in terms of her individual characteristics, relationship, community, and society playing a role in her anxiety. You can unmute yourself and you can talk to us. Okay. So
Can you hear me?
Sorry.
Go ahead, Heather.
I think someone else was trying to talk as well.
Yes. I just wanted to say, so for instance, with her community, what is her neighborhood like? What's the level of violence there? Is she exposed to hearing gunshots, different kinds of things? And in her own relationships, does she have a background of violence in her relationships? Maybe she's come a long way through therapy, put a lot of that stuff behind her, but has some reminders, and so she gets triggered when she sees things happening in the news and so on.
Yes, absolutely. I appreciate your comments. And then the other thing that we're thinking about is that in terms of social cultural, right? As a woman of color feeling targeted by hate crime, right? Being affected by hate crime, it's normal to feel this way, right? So when she came back to therapy, one of the things that we had addressed is that normalizing some of those feelings, right? It's normal to have that increase of anxiety based on some of those experiences that you have had, right? And being able to see if there's any other areas that we have missed before that needs to be addressed. But being able to validate the patient's experience is really important. And with her, validating her experience really helped ease some of her anxiety symptoms to feel like she was not losing control or she was not going crazy is normal to have some of the experience when you have all of those layers going on, and be able to help her process what was going on for her and reestablish some sense of control of some of the things that she can do to protect herself and to protect her family. So that was also the beauty about having integration with primary care and mental health. So we are going to the second case. And the second case was also one of our patients, a 30-year-old male who presented for therapy to manage back pain. And he also had anxiety that was associated with his back pain. During the intake, he reviewed a history of complex trauma, and his experiences had turned into rage. And he also was a perpetrator of gun violence. So again, as we think about this case, right, let's try to unpack in terms of some of his individual characteristics. And I purposely left some of the things out there for us to think about different possibilities, and then think about his relationships in terms of support and not support, and I'll think about community and society. So who would like to make a few comments about this case?
Yeah, I feel like a lot of my patients have that trauma history and adverse childhood experiences, and then maybe don't have the family support or like the social support to deal with situations like this. Even when they have, you know, a medical problem, it kind of gets magnified because they don't have that support network that some other patients may have.
Yeah, Heather, and that is such a good point, right? Because trauma also affects, especially trauma that happened during childhood, right? And we increase ACE scores, impact our ability to manage our feelings and our emotions, right? And especially when it's not therapeutically addressed. So that also can impact this patient with his ability to cope with pain, right? And to cope with different things. So when we start unpacking, you see this history of trauma that haven't been addressed. And more specifically, especially I find with some of my male patients, right? And it depends on which ethnic background they come from. In their culture is like, men don't have problems, right? You're not supposed to really talk about your problems. You're not supposed really to go to therapy. So then even delaying the entrance in therapy to be able to work on those trauma that can have a negative impact on his physical health. Yep. So the third case is also a case here from our clinic, is a 7-year-old female patient. She presented to the clinic with increased depression, and she revealed that both of her sons had been murdered. They were shot. And patient was recently diagnosed with bipolar disorder and was receiving therapy. However, her trauma and her grief had not been addressed. And that's one of the things that when she presented to the office, we do basic screenings for depression, and she was just sobbing, crying, and talking about this very recent experience. So again, when we're looking at her and we think about the individual relationships, community, and society, what comes to mind for you in her case? So one of the things that we think about, you know, as 7-year-old woman, she lost her two children, adult children, to gun violence, and that was on a street fight. So imagine how she's grieving that loss, right? And also the loss of the relationship, and how safe even she's gonna feel and continue to feel in her neighborhood when the violence had happened right there. And thinking about other influences on not feeling protected that can be more related to some of the social cultural barriers that we're talking about. So for our office, one of the things that we have talked to her, she had some insurance concerns, health insurance concerns. So we're able to connect her with social work and also to find her a grief support group to help her process that loss. And also trying to figure out a trauma therapist for her, because that's one of the biggest barrier also in mental health, the difficulty to locating therapists that can provide trauma therapy as well. So. And do you have in your clinic, I know Heather was telling us a little bit, so do you have in your clinic anybody or any case that you would like to talk to us about? All right, so as we move on and you think about these layers and how it affects our patients and our families and our communities, one of the things for us to think about is the role of the primary care physician.
Right. Thank you, Dr. Canero, for sharing many of these cases. And as you can see, we might think that there's not much a family doc can do in a day-to-day in the office, but indeed, we actually have a lot that we can do. We need to be at the front line helping our patients, their family, and their community in early detection and prevention of gun violence. It's important, before we're addressing it, is to know the rate of gun violence in your practice area. That way you can share with the patient and help each other in understanding and addressing the importance of talking about gun control and violence in our area. So in the Gun Violence Archive webpage, this is a sample of the screenshot of the internet page. You can see here, they break down gun violence into many different types, as well as the map of our country. So from unintentional shootings to defensive use, home invasion, teen killed and injured during 2022, children killed or injured, and number of injury in 2022. And even if just as a glance, you can see this map of our country showing lots of red dots, mainly in the East Coast and the South, with some on the West Coast, the far West as well. So that's the area where most of the gun violence occurred. In the next page here, you also see number of deaths by gun violence. Subject, suspect, perpetrator, shot or kill, officer shot or kill, as well as mass shooting. And again, you see the submarine pattern of more to the East Coast and the East Central and to the South. At least then we can have an idea how prevalent gun violence is in our community. So we talked earlier, one of the goals to address is preventive strategy, and we're going to go in different layers. So first we're going to discuss individual, then at the practice, and then at the local community. So individually, first, ask the patient and family if they've gun in the home. Simple as that. In all of our well child visit here in the office, that's one of our questions on the smart set on the electronic health record is their gun in the home. And if the answer is yes, then the next step is to discuss safe storage of firearm and ammunition and encourage participation in gun safety class. As you can see in the picture on the right side, children are naturally curious, and so are adolescents. So they don't stop when they said not to touch, not to go, right? They're gonna even explore that area even more. And kids are safer when the firearm or ammunition is stored in a safe box, but it's safest when they're not even in the home. And we'll make sure to keep the safe in the firearm safety class. So there are different kind of locker to keep handgun versus rifle versus trigger locks versus safety box for ammunition. And these are the feature that as healthcare provider, when we see children and family, we need to address with the parents. And from the American of Pediatric that I alluded to earlier in the opening talk is we need to, as frontline healthcare worker, urge and counsel parents about the danger of allowing children and adolescents to have access to gun inside or outside the house. And the AAP recommend that we should incorporate this into well child history taking at every preventive care visits. If it's positive, we need to discuss safe storage. and emphasize that the best and safest home is the one without firearm. Besides just the safety of gun usage, we need to be aware that the presence of gun in the home actually increases the risk of lethal suicide among adolescents and children. And healthcare professionals should counsel them about removing gun from the home or restrict access. And more importantly, pay attention to home where the adolescent and children are dealing with mood disorders, substance abuse, including alcohol, as well as history of suicide attempt, because this increased the risk of injury and death from gun violence. Continue on with strategy for individuals. So besides screening for gun and talking about gun safety, we need to screen for other mental health condition or related conditions. So first of all, screen for depression in general adult, in pregnant and postpartum women as well. And those who screen positive need to have further assessment for severity of depression and other comorbidity of psychological and medical condition and refer for appropriate treatment. So this is in terms of the U.S. Preventative Service Task Force. This is recommendation level B, which is there are moderate amount of benefit outweigh the risk, and we should screen all patients. Next page showing you that the most common screening tool that we use is the patient health questionnaire, which is the 9-point questions, and we need to have a structure for appropriate follow-up and address it for patient in the clinic. Besides screening for depression, we need to also screen for intimate partner violence and refer screen positive woman to intervention service. Studies show that if there is gun in the home, the woman will die due to intimate partner violence related homicide by 8-fold. So increase the risk significantly for women that suffer from intimate partner violence when there's gun in the house. And the abuser who possess gun tend to inflict the most severe of the abuse. So it's very, very important to screen for intimate partner violence. And again, you'll see that this is a screening of grade B by the U.S. Preventative Service Task Force, which again, the screening had moderate benefit over any risk. So once we address at the individual level of questioning about presence of gun and safety feature, along with screening for depression and intimate partner violence, let's talk on the practice level. It's important to have a protocol in place to deal with crisis, and limiting firearm access at workplace prevent a lot of violence related in workplace. The picture on the right shows you that even though only 20% of workplace injury happening to healthcare worker, 50% of healthcare workers are victims of many of the workplace violence. And so it's very, very important as we are out there in the front line addressing the healthcare and safety of our patients that we need to look after our own. And there are some barrier of why does the healthcare worker tend to suffer more of the injury. There's certainly some barriers, including lack of action resulting from reporting. So there's reporting, but didn't lead to anywhere. Or varying in perception of what constitutes violence. There might be bullying, there might be money and profit-driven management model, or lack of management accountability. Also, like many of the service, we tend to be customer service in healthcare organizations. So we tend to try to be, people pleaser, please our patient, please the patient that come to us, but that is certainly could be a barrier to address violence in workplace. And then weak social service and law enforcement approach to mental health patient. So here are some practical recommendations from OSHA that we can address, so in many layers. So in terms of worksite analysis and hazard identification, certainly we can incorporate some walkthrough survey, asking employee about hazard. And if the employee describe any hazard or concern that need to be addressed. From an administrative and work practice level, we could devise a strategy so that employees do not work alone, or they have a counter partner to keep check and balance. In terms of engineering and workplace adaptation, we can utilize some panic button, security officer access control, lighting, and visibility. I remember when I was still a resident in our office, we don't have any locked door whatsoever. And after a few incidents of patient with rage and stuff like that, we had to talk to the hospital system. And now between the front office where patients sit to the back office where we see patient, there's locked door that we can bust to get it through. We don't have a panic button yet, but at least they have structure in place to contain violence. Or the next technique is in training is utilize education. So in our network, Dr. Canero, along with a few other GME and hospital staff, put together a module, online module, so that we can all learn and get trained on de-escalation technique and risk recognition. So recognize when the patient have sign symptom of rage and escalating of their voice or their feature or their posture, and then how do we address and de-escalating technique to the patient, but also to activate a crisis protocol. So we have a text messages system in our office as well as hospital to activate, like if we see a patient in crisis, so that we can notify the social worker, notify our behaviorist, notify the medical director, so that we can kind of all get to the scene in a calm and composed manner to de-escalate any potential violence. And then lastly, with anything, we need to have a system for record keeping and program evaluation. So if an incident happened, how do we report? How do we learn from it? And how do we debrief so that we can prevent it from the next time that it might occur. So these are some structure recommended by OSHA, but some of these we actually already implemented here in our residency and clinic, and it definitely helped addressing and preventing violence.
So in terms of prevention, when we created those protocols for the crisis, that we got together our interdisciplinary group, and one of the things that we have as a meta framework was trauma-informed care, and really making our institution a trauma-informed care institution. Because in terms of talking about preventing that escalation of behavior, is being able to understand our patients and also each other in our system from a trauma lens, and create an environment that we feel safe working. And we are able to recognize some of the signs and intervene before they escalated, and have those systems and checks and balances in place to make sure that what we're doing is actually working. When we developed the MEL training, which is my e-learning training, there's virtual trainings on trauma, on crisis. We also addressed from a trauma perspective lens, and having some case scenarios that actually happen here in the clinic with our patients. So our front desk staff can recognize and identify that, as well as our clinicians and everybody in between. We also like to talk about the FP guidelines of trauma-informed care, and think about realizing the widespread of trauma. Trauma is prevalent, and recognize the symptoms that are associated with trauma in our patients, their families, even our staff and our community, and how we respond to that, how we respond to trauma, that we can integrate that not only in our knowledge about trauma, but also into our policies and our procedures. Like Dr. Lamb was saying, the ability to say, you know, this happened, we're trying to prevent from happening, but this happened and we report it. And then when things are reported, there actually some kind of response that is an appropriate response, right? Because we want our patients to be safe, but we also want our staff to be safe. So it's important to go both ways. And then resist re-traumatization, be able to know and pay attention to our language, and use a sensitive language that we can resist re-traumatizing our patients, ourselves, and our staff. And here we have some resources on training and connecting, training clinicians on trauma-informed care, and some other resources on connecting clinicians and patients with resources. When I was talking before, I mentioned the case of the patient that was having a hard time locating a therapist who could provide trauma therapy. So the VA has a lot of different resources for patients with PTSD. They're all free resources, and we're able to use them and download them. And then also having a system in place, and that is a very good resource on how to guide and implement trauma-informed care a little bit more systemically. And the example that we have here in our own clinic and network is what Dr. Lamb talked about, our crisis plan and response that is across of all of our offices and residencies in the network. And so we think about where we're going from here, right? So one of the summary points that we talk about is to screen and address gun violence at home and having a safe storage for the guns, and make sure that we talk to our patients about it. Is screen and address depression, IPV, any other mental health, and specifically trauma, and pay attention what the facts of trauma are, not only on individual patients, but also in the families in the community at large, and be able to advocate for our patients, and review current workplace settings and institutional measures recommended by OSHA to prevent workplace violence. And these are some of the references that we have used. And do you have any questions for us?
Thank you. That was really excellent, and gave me a lot of food for thought. I have a question about screening, especially at pediatric visits. Maybe partly because I'm in New York City, but I find if I ask families if they have guns in the home, I usually get either just like giggling and no eye contact, or like people who are really startled and confused. So I'm wondering if you have some suggested language for the best way you ask that question.
I usually frame it in the context of safety for the kids. So I usually just say, as family physician, I'm always looking out for the safety of our little children as well as the entire family. So this is part of my routine screening question. So I kind of try to normalize it. And I said, one of the safety features, just like lockbox and little toilet seat for locking for when we screen a 2 years old and start to crawl around and run around, is for children and adolescents. We ask if there's a gun in the home. And usually when I kind of set the stage like that, the parent tend to be kind of at ease. That is, this is part of now my routine screening. I'm not suspicious of any activity. I ask everybody this, so I normalize it. And then usually with that, I get a better response. And most of my response has been, no, we don't have gun, but a few families have gun. And they usually go on before I even ask. They'll say, oh, I have gun, but I keep it in a lockbox. Oh, I have gun, but it's high in a lock place in the garage that my children didn't know about it. A few of the household I talked to, they actually, one family was very concerning. They have gun and they actually teach the kid how to use it. And I was like, oh, and you know, I got reassured that the kids understand and use it safely, because they take the kids to these area shooting range that they train. And I said, if you're going to do this as a leisure professions safely out there with, you know, guided professional to teach you this, that's fine. But I again reiterate the recommendation from American Academy of Pediatrics is the safest household is the household without gun inside the home. And if it's inside, even though your kids know how to use it safely, still it has to keep it locked with safety feature, because you never know when the curiosity or the mental health kick in little kids, adolescent, that now it become a rage. And then we can at least prevent self-injury and injury other accidentally.
I have a question. I was a little surprised to see the statistic about such a high percentage of assaults happening in healthcare settings. That was not something I knew. And I wondered, since so many of you work with medical students and residents, is that kind of commonly known for people coming up in the medical field, or is it something that you share with them as part of training? And then could that be sort of a motivator for them to be more proactive about addressing violence? That was my question.
Yeah, so from a primary care perspective, thank you, Scott, for your questions. This is certainly something that we share in a national platform like FMEC, but also in residency training is to share with our residents to address this. But I would say it's more common than I thought. So I belong to the Pennsylvania Academy of Family Physicians, and a couple of years ago, when all the PD gathered for one of our regional state PFP meeting, the PD from Jefferson show up, and literally 2 days prior, a nurse aide walk up to go through all security and 9th floor of Jefferson Hospital and start shooting. And they actually accidentally calling the a code. So with the code, every healthcare worker run to that, right? And you run to an accident area where there's an active shooter still in the house. And with that, the Jefferson Health System really have to revisit the whole protocol of you can't activate a code in that case. You have to call it a different kind of code so that we know that it's kind of a violent in which the shooter is still in the scene, so that you don't draw more worker go into preventing injury, right? But, you know, I'm thinking of our own office here, and my office is right next to the patient lounge area. And I also think about scenario like this because we have patient in rage and stuff like that. We have not have patients showing up with gun in the office, but we have patient with rage. And what happened is I would always think to myself as a leader in my workplace, what do I do if an active shooter show up, right? Obviously, I'll be among the first, go and address, and we'll see how low we can tackle that. But techniques like the escalating technique, and if not, you know, one of us has to at least sacrifice for the sake of saving our patients and the crew. And certainly these are things that we have to be prepared. Hopefully it never occurred, but with the rate of gun violence increase in our community, we need to try our best to prevent the visit, address with patient and family to prevent it before it occurred, address mental health proactively. But in case it occurred, beside locked door and safety feature is to kind of create scenarios that we practice among our team as to what to do, where to direct patients, and the exit door and all that, to kind of almost like a mock code, so that in case an unfortunate event happened, we minimize the injury.
Well, the other thing I also think is really important and crucial to pay attention to is not minimizing any warning signs.
Mm-hmm.
One of the things that I have noticed, and more specifically with our residents, I think is that in the nature of I have to do everything in my ability to help my patients, which I agree, but we cannot minimize when your patient make any threats, right? And I see that quite a lot with patients who have some mental health diagnosis and are looking specifically for certain kind of medications that perhaps the family physician doesn't feel comfortable prescribing and would just fill that gap until they go to psychiatry, right? And the patients start getting frustrated, right? And escalating and making threats and say like, I'm going to harm you if you don't provide me with this medication. Those are things that we cannot take lightly. And sometimes I have heard many times some of my residents saying, oh, no, we know this person's just frustrated. No, that's a threat. A threat is a threat. If anybody say anything like that directly to you, is something that has to be taken seriously. And we have to activate our system in place. So I think that the importance of educating our physicians, our residents, is crucial.
Well, I just wanted to thank both of you for a really important and thought-provoking topic. Really appreciate this focus on our unfortunately next national pandemic, and I look forward to seeing what you present at the upcoming meeting in October.
Thank you.
Thank you. Thank you for having us.
Yes, thank you.